Welcome. As you join the webinar today, please take a moment to answer the demographic questions. Hello, my name is Judith Currier, and I'm from the University of California in Los Angeles, and it's my privilege to be here today and to welcome you to this webinar on the prevention and treatment of opportunistic infections in persons with HIV. Please take a moment to answer these demographic questions. Be helpful for us in planning future events and understanding our audience today. I've just a couple of introductory slides to get us going. The IAS-USA content on the web board members are listed on the slide, and these are their financial relationships with companies in the last couple of years. Our presenter today, Dr. Mazurs, has no financial relationships, and I've reported consulting fees from Merck and Company. On to the next, the CME information to this program is accredited by the International Antiviral Society USA, IAS-USA, and it is designated for 1.25 AMA PRA Category 1 credits. It's also been approved for the following credits and points for the various different types of activities. Grant support is listed here. The contributors for the funding for this program are shown on this slide. And today we are going to have questions and answers, and we'll be monitoring the questions. So please put your questions into the Q&A section of the webinar. If you put them in the chat, we'll move them over. I'm going to be sort of collating them as we go along, and we really do hope to have plenty of time at the end to have an interactive Q&A session. So please, as you think of questions, put them in, and thank you to those of you who submitted questions ahead of time. Some really great questions. It's clear that this topic is of great interest to people. So we're glad that you're all here with us today. So it's my pleasure to introduce our speaker, Dr. Henry Mazur. He's the chief of the Clinical Care Medicine Department at the NIH Clinical Center and one of the founding directors of the NIH CDC IDSA guidelines for management of opportunistic infections. He's really been a leader in the care of people living with HIV with opportunistic infections over several decades. And it's really great to have him here with us today to really update us about what's new and to remind us of some of the important principles for managing opportunistic infections. So thank you so much, Dr. Mazur, and welcome to the webinar. We look forward to hearing your remarks.
Great, thanks very much, Judy. I think opportunistic infections are a good topic because whether you're doing outpatient medicine or inpatient medicine, I think we all deal with these. And a couple of the themes I'd like to develop is that in the 1980s and 1990s, we had a lot of data-based recommendations for diagnosis and prevention and therapy. As time goes on, there have been fewer trials, so more and more expert opinion comes in. And in the question and answer, maybe we'll get into some of the issues about some of the recommendations of the guidelines that are scientifically based, but not followed by many people, and whether that's a good idea or a bad idea. As Judy indicated, I don't have any financial relationships to report. The learning objectives are to describe why people with HIV continue to develop OIs. Well, I suspect that the people in this audience know full well why that's the case. We're going to talk about some of the newer diagnostic approaches, some of which I don't think are necessarily a step forward, even though they're technologically sophisticated. We're going to talk about strategies for prevention that are sometimes overlooked, and talk about how to manage some of the common HIV-related infections. We want to ask you a question, first of all, whether this audience, so that we can know how to focus some of the questions, do you do inpatient HIV work or not? And it's a yes or no, and hopefully everybody will get this one right. So let's see, I'm assuming at some point I'm going to see the answer. Okay, there we go. So 30% of you do inpatient. All right, so that's good to know. All right. So let's see right now. Okay, now we're going to do two pretest questions, and this is the first one. Which of the following is the most sensitive test to detect cryptococcal species in the CSF of a patient presenting for the first time with newly diagnosed HIV, fever, and headache? In other words, you think they have cryptococcal meningitis. So is the most sensitive test the crypt antigen, the crypt PCR, the India ink smear, or the crypt antibody? So we'll give you a few minutes to answer that, or at least a few seconds. And this will help determine whether this is something that's too easy or too hard. Okay, so a few people took the bait for PCR, and it's good we can talk about that. So the second question is, a person with HIV has just initiated antiretroviral therapy. They have a low CD4 count and a high viral load. Which of the following immunizations is contraindicated? And you can only choose one, and there'll probably be some debate in your mind about at least two of the answers. So let's see how you vote. Okay, so 80% of you got what I thought the right answer was, MMR, and we'll talk about that ultimately. Okay, for the first question I wanted to pose, I suspect everybody in this audience knows the answer to. Why does anyone in the US develop an HIV-associated opportunistic infection in the current era, where we have great HIV diagnostic tests, we have great antiretroviral therapy, and hopefully everybody has access to care, although we know that's not always the case. If you look either at the CDC data nationally, if you look at Ryan White data, or in this case, if you look at data from the District of Columbia, where we have a project on urban HIV, I think everybody probably sees the same thing, that if you look at all the people living with HIV and look at the cascade of care for those who are ever linked to care, those who are retained in care, and those who are durably virally suppressed, we all know that there's a substantial number of people who, for a whole variety of reasons, are not durably suppressed. And as is obvious to everybody here, these are the patients who get opportunistic infections. And IAS-USA has sponsored some other great symposia on how we can get more people durably suppressed. That's the topic for another day. One of the questions also is, how common are HIV-related opportunistic infections in the United States? In the 1980s and 1990s, there were a number of networks that were funded that reported very granular data. Those are not funded anymore, unfortunately. And HIV-related OIs are not a reportable disease. So we really don't know what the frequency of these are in the United States, although there's some good small reports out there. One of the things you have to be careful of, though, is when you look at reports, whether they're coming from big networks or smaller studies that look, for instance, at the, quote, fungal burden in the United States that might look at pneumocystis, they often use ICD-9 codes or clinical assessments that don't really give you the kind of precise data that you'd like. Because I've been working on the guidelines for a long time, I think the guidelines give you some window on how often providers at least think they're dealing with opportunistic infections, and hopefully that's the case. And these are data from the 5 NIH-sponsored guidelines on HIV. The one on the left is for antiretroviral therapy. The 3 on the right are pediatrics. The one we're focused on is circled in red. And that shows there are about 500,000 page views on opportunistic infections per year. So there are a lot of providers, mostly in the United States, but not all of them, who are concerned about the most up-to-date knowledge, and they presumably want this information in terms of how to manage specific patients. Interestingly, if you look at the pages that people are accessing, what we used to call the big 5 infections in the 1980s and 1990s are still the big 5 in terms of frequency of access. It's pneumocystis, cryptococcus, toxo, mycobacterium avium, and CMV. So those are still what people are interested in, although I think these guidelines are also useful for the tail end of this, for diseases like microsporidia or leishmania or malaria, where probably most of us don't know what to do with somebody who's HIV infected, and find these guidelines very useful. But again, the left side of this, we're still interested in the big 5, and there are some changes that we'll highlight and some things to review. Now, in terms of prevention, before we get into diagnosis or therapy, what are the 2 major approaches to prevention? One is chemotherapy, chemoprophylaxis. The second is immunization. If you look at primary and secondary prophylaxis, just to remind you, in case you've forgotten the distinction between primary and secondary prophylaxis, primary prophylaxis is preventing the first episode from occurring. So in somebody who's either never had an opportunistic infection, or maybe they've had one, you don't want them to develop something else. And there, the focus in 2024 is on pneumocystis and toxo. And again, I think everybody in this symposium is aware of what the CD4 criteria are. We don't tend to focus so much on the clinical criteria that we did earlier in the HIV epidemic, where we were looking for clinical indications of immunologic susceptibility as well as CD4 counts. Now it's mostly CD4 counts. And again, it's 200 for pneumocystis, 100 for toxo. Hopefully everybody in this audience is also aware of the fact that we no longer recommend Mycobacterium avium prophylaxis. And the reason for not emphasizing primary prophylaxis there is simply for reasons that are not fully understood. We just don't see much Mycobacterium avium anymore. And when we do, we have good drugs for treating it. So we don't recommend that anymore. And it's always a balance between the benefit and risk or cost. There are 2 other prophylactic issues in terms of primary prophylaxis just to be aware of. There's sort of niche issues in terms of coccidioidomycosis. If you live in an endemic area of patients who have been there, the recommendation is that if your CD4 count is below 250, why this is something other than a multiple of 100 is an old story. But if you have a new positive IgM or IgG and your CD4 count is below 250, you ought to get itraconazole. And there's some experts who would give histoprophylaxis with itraconazole in immunosuppressed patients if they're with CD4 counts less than 150 or 200, if they're in, quote, high-risk situations. What a high-risk situation is sort of vague, but it's worthwhile to just be aware of that. In terms of secondary prophylaxis, that's the prevention of recurrence of infection after you've treated toxo or mycobacterium or CMV. And for pneumocystis, it's prevention of both relapse and recurrence of a new infection. So we distinguish between primary and secondary. And in terms of how long to continue primary or secondary, the guidelines provide these things that you can look up in terms of how many months they've had antiretroviral induced immunologic reconstitution, if you consider 200 reconstitution, and whether it's 3 months or 6 months is really based on data which is from the 1980s and 1990s. I suspect that many of you suspect and may practice the fact that with modern antiretrovirals, you probably don't need the CD4 count to go up quite this high. And if they're virologically expressed, you could probably stop before 3 months or 6 months. The problem is we really don't have data. During the Q&A period, we might talk about what people actually do, but the guidelines still recommend this because this is safe. The prophylaxis is generally well tolerated. So this is safe to do, but it's probably in 2024 with the antiretrovirals, we have a little bit of overkill. Now, what are the preferred drugs? I saw there's some questions that already came in on what the preferred drugs are. If you're dealing with pneumocystis or toxo, it is always best to use trimethoprim sulfa, either prevention or therapy. There's nothing that's easily available that is superior to trimethoprim sulfa. If you're talking about prophylaxis, there are a lot of old studies that look at once daily versus twice daily, single dose versus double dose, 3 days, 5 days, or 7 days. I think all the regimens are very effective. You can make the case that if somebody has a CD4 count under 100 and they're toxo IgG positive, you get more toxo prevention with a higher dose everyday regimens. But I think those are all fairly esoteric reasons. And the fact is, if somebody will go on antiretroviral therapy and drop their viral load, you probably don't need protection for too long, but we still go with the duration I showed on the previous slide. Atovaquone is a good drug for prophylaxis. It is not well absorbed if somebody can't eat, particularly what they call a high-fat meal. But I think generally that is a good drug. I don't think many people use dapsone for a variety of reasons anymore. And the one thing to remember about aerosolized pentamidine, really two things to remember, is number one, it is a very good prophylactic agent, but not as good as trimethoprim sulfa and probably not as good as atovaquone, although the studies would say they're equivalent. And it is aerosolized pentamidine is specifically not active against toxo. So if you have somebody who has less than 100 CD4 counts and they're IgG positive, you're going to have to think, if you're using aerosolized pentamidine, what you might want to add for toxo. And there are not a lot of good options in that situation if you can't use atovaquone. So let's just make one other point. There is one new drug for pneumocystis that we'll talk about later that is like atovaquone, but it doesn't appear that it's being developed clinically. So in terms of prevention, let's move from pneumocystis to TB. This is something for the question and answer period, is how many people actually follow the guidelines on TB? Because the CDC feels very strongly about this, and it certainly all makes sense, even though most of us are not seeing a lot of TB, certainly in US-born individuals. But the recommendations are that every person with HIV should be screened for latent TB. And the screening, of course, is either a PPD or an IGRA. It's recommended that you not do both because you'll just get confused. But what the CDC would report, based on some Cochrane analyses and other meta-analyses that are not entirely current, is that we don't do a very good job of screening for latent TB or starting people on chemoprophylaxis. So they would estimate that only about 40 to 70% of people ever complete their screening. And of those who complete their screening, less than half ever initiate therapy for latent TB. So this is something that many of the experts feel strongly about. And actually, if Judy can make a note of this, it'd be interesting to see how many people actually do this. Maybe we could get some comments on that. So again, I think everybody knows how to screen with a PPD or an IGRA. One of the things that I think is often overlooked is that if somebody is a close contact with somebody with active pulmonary TB, they should get prophylaxis regardless of their CD4 count. How you define a close contact, CDC has a lot of information on that. I think you can probably make reasonable clinical decisions based on common sense most of the time. And of course, as with many things, if your PPD is negative, you have a CD4 count under 200, you should retest when they're over 200. How often that actually gets done again is an issue. And obviously, if you're treating somebody for latent TB, you need to be sure that they don't have active TB and hopefully at least get a chest X-ray. So there's a lot of debate about how to treat latent TB. The CDC and the NIH guidelines don't entirely agree. And I'll tell you where there's disagreement, even though the CDC is one of the sponsors of the guideline. And there have been some changes, and the two regimens that are recommended currently, one is a weekly regimen for 12 weeks. The other is a daily regimen for 12 weeks. And you can see here, one is isoniazid rifampicin with pyridoxine, but you have to be careful that they are on a antiretroviral regimen that isn't affected to make it ineffective by the rifampicin. So that's efavirenz, raltegravir, or once daily dolutegravir. And again, with the isoniazid rifampicin regimen for 12 weeks, the daily regimen, you obviously have to be concerned about rifampicin as well. Where there is controversy is the last regimen. If you're a traditionalist and like isoniazid 300 milligrams a day for 6 to 9 months for pulmonary disease, particularly if you have directly observed therapy, that's a perfectly good regimen, just obviously hard to adhere to and more toxic. The 4-month rifampicin regimen is fine, except that there are a lot of drug interactions. So there's been a lot of controversy about the 1-month regimen of isoniazid and rifampicin. It obviously would be wonderful to have a 1-month regimen. There's a lot of concern about the study in that it was done in Africa. Many of the patients were at risk for TB because of exposure, but they didn't have a positive PPD, or they didn't have a PPD placed. So the study was not entirely relevant to the United States. It had a small number of endpoints. And if you look at the drug interactions, there are a lot of people who feel strongly that you should only use it for an efavirenz-based regimen, which probably there are not that many patients on. So there are strong advocates for this 1-month regimen. There are people who don't think it should be used in the United States, but at least the guidelines say it's an alternative, even though the CDC in their TB guidelines say not, they don't recommend it. I'm not sure if they say don't use it, but they don't recommend it. So again, something that you might want to use in your practice if you want a 1-month regimen and you think you know enough about the interactions of rifampicin with other antiretrovirals to do this. But it's, I think, a more complicated regimen to be sure it's going to be effective than the other ones. So let's move from chemoprophylaxis to immunizations. This is a chart I don't expect you to absorb that comes out of the guidelines. And it makes the point in terms of the immunizations that are in green, in that there are a lot of HIV-associated opportunistic infections and a lot of other infections that you can prevent in this vulnerable population. But it takes a certain amount of clinical organization to make sure that patients are interviewed about whether they've been immunized before, in some cases, whether they have serologic evidence of previous immunity. So this takes a fair amount of work to make sure that you're implementing this. There are 2 issues to keep in mind. I think that everybody in this audience has the common sense not to use a live virus vaccine, which are in red here, for somebody who either has a measurable viral load or has a CD4 count under 100. And again, just to remind you which the live viruses are, is measles, mumps, rubella. So that was the right question on that pretest. It's varicella, which is not to say you can't give the zoster vaccine. You can give that because that's not a live virus. You can't give the varicella. And I don't think very many people use live attenuated influenza, but you shouldn't use that for anybody, even those with over 200. Just to remind you, if you have patients who are traveling, again, I don't know how many people with a CD4 count under 200 and a measurable viral load or a measurable viral load are traveling, but yellow fever is a live virus, and the live attenuated typhoid is a live bacteria. Just one piece of arcane knowledge is that for the Mpox immunization, the Jynneos vaccine, which is the one that's recommended now, is a live virus, but you can give it because this is the one attenuated virus which is designed to be non-replicating. So this is safe, and this perhaps violates the rule that you can't give a live attenuated virus. But again, this is a special live attenuated virus. There are a few newer considerations. Again, a lot of information, but there's some nice tables in the HIV guidelines. For HBV vaccine, the Heplisav adjuvanted vaccine has been moved up from an alternative to a recommended. So it's recommended as well as the two recombinant viruses. And the advantage of this is there's 2 doses rather than 3 doses. But as with the recombinant non-adjuvanted, you should assess titers 1 to 2 months post-vaccine, make sure they have 10 international units per mil. I'm not sure how many people really do that, but at least that's part of the recommendation. The recommendation for Pneumovax have always befuddled me in that there's so many permutations about somebody's age, whether they got a Pneumovax before, how long ago they got. To me, if you look at the guidelines, the easy thing to do is just to give everybody the conjugated PCV20 vaccine, because no matter what they had before, this will complete their lifetime need for a pneumococcal vaccine, and a repeat is not recommended. If because of price, availability, or something else, you can only get the 15-valent vaccine, that's fine, but then you have to give the polysaccharide vaccine 8 weeks later, and that's just one more thing to remember and get the patient to come in for. Now, meningococcus is not an HIV-associated opportunistic infection. It's not more frequent, and it's not more serious in people with HIV, but because of lifestyle issues or risk factors, patients with HIV have a higher incidence of meningococcal disease than most other patients. Just to remind you of 3 things. One is we used to use a trivalent vaccine. Now we use a quadrivalent vaccine. That should be given every 5 years. The meningococcus B is not included in that, and it's not routinely recommended, although I don't see any reason not to give it unless cost is an issue. And again, I guess I've repeated this. This is one of the few vaccines that you ought to get, that you need to give periodically. I'm trying to think off the top of my head if there's anything else. I guess it's influenza you give every year, but meningococcus you give every 5 years. Most of these other things you don't repeat unless you have serologic evidence that their titers are dropped. And again, with Mpox, that is given to anybody who is exposed, likely to be exposed, or asks for it. I know that IAS-USA has given a symposia before on this, but again, there's a good summary in the guidelines. So what do we know about diagnosis of opportunistic infections? And I think when Judy and I were embarking on our careers, the diagnosis were pretty straightforward because we get a tissue biopsy or we get a stain on some kind of sample. So although it may not have been so risk-free for the patient, at least you knew for sure what diagnosis you were dealing with. So let's ask a question, and then we'll move into some information. Again, your typical patient with no CD4 counts and a high viral load comes with 1 week of a fever and a headache. The lab reports that his CSF biofire panel is negative, including for Cryptococcus. How do you interpret this result? This is definitive evidence that the syndrome is not due to cryptococcal disease. this could be Gattii, but not neoformans, or this could be Gattii or neoformans, and you need to ask the lab to do another test. So let's see quickly how you respond to that. And it looked like from one of the pre-tests that you have a good idea of how to make the diagnosis of cryptococcal disease. Okay, so most of you said, okay, most of you know the right, 75% of you know the right answer, and that is what we're going to get into as to how you interpret the BioFire. So, you know, PCR, I think, is obviously a wonderful advance in diagnosis, but it creates some problems in terms of its lack of specificity. I guess the point I'm going to try to make is that PCR is very sensitive, although there are a few situations like cryptococcal disease, for reasons that not even Robin Patel at Mayo, who supervises most of the tests you send her, even she hasn't been able to explain to me why the cryptococcal PCR in the spinal fluid is not as sensitive as a cryptantigen. So we know that the PCR is biologically specific, but as I'll probably perseverate on several times, it doesn't really distinguish colonization from the pathogen. So when you find an organism by PCR, how certain can you be that it's the cause of the syndrome you're trying to evaluate and not a fellow traveler? So I'm going to show you two kind of panels, a respiratory tract panel and a CSF panel. So these are panels from two of the commercial vendors, and it shows you what the organisms are, bacteria on the left, viruses here on the right, followed by a fungus and some resistant genes. And the point is that for many of these bacteria, finding the bacteria doesn't necessarily mean that that's the cause of the pneumonia. It may be a colonizer. Now, admittedly, if you find chlamydia pneumoniae, Legionella, mycoplasma, those don't tend to persist that long in terms of they don't persist long after an acute event. So if you find them, they're probably the cause. The other ones you're really not sure. With viruses, it's great that they find a number of viruses here. And again, if somebody has not had a viral event in a long time, you can probably think that this is probably the cause. But people, particularly immunosuppressed people with high or low CD4 counts or other kinds of immunosuppression, tend to shed these for long after they've had an infection, even if it's a relatively mild or asymptomatic infection. So when you find these viruses, you're still not 100% sure that this is the cause of what you're looking at. And particularly if you're dealing with somebody who has low CD4s and might have pneumocystis, you really have to think, do I stop with the virus or is there something else? I'm going to talk to you about pneumocystis in more detail in a moment. But the problem with pneumocystis is the same thing. Pneumocystis can be a colonizer, so that when you find pneumocystis there, you don't know whether it is a colonizer or the cause of the infection. So the point is, PCR is great, but it's very sensitive. It isn't always specific for what the cause of your disease is, and you have to just keep that in mind. If you look at the BioFire, in particular their meningitis encephalitis panel, just to make the same point, if you look at the viruses they detect, if they report to you that there's HHV6 there, yeah, there are a few cases, and I bet there are people in the audience who've seen a real case of HHV6 encephalitis in somebody with HIV, but it's pretty unusual. So if you find HHV6, you really need to think, is there something else I'm missing? And use this really as a last resort in terms of diagnosis if you're basing it solely on the PCR. And then on the other side here, cryptococcus, we mentioned 3 times now. For some reason, there's some people who are PCR negative, but cryptantigen positive. So you just have to keep that in mind. And if somebody you think has cryptococcal disease and their PCR is negative, or as we'll talk about in a few minutes, even if their cryptantigen is negative, you probably should treat them empirically until you get more information. So let's talk about HIV-associated pulmonary disease. This is a typical patient with cough, fever, and diffuse interstitial infiltrates. Before we talk about opportunistic infections, just keep in mind that you can't jump to the assumption that everybody with HIV and a low CD4 or a high CD4 has an opportunistic infection, particularly when patients are febrile with something else. Keep in mind that if we see more older patients, more patients with stimulant-induced cardiomyopathies, the fever may throw them into congestive failure, and they may have some other cause of their fever. They may have sepsis or something, and their pulmonary infiltrates are just failure. And again, you can get people who are hypoxemic due to pulmonary emboli. You can get people who have infiltrates, may even have fever because they have pulmonary KS or lymphoma or lung cancer. So again, just don't jump on infections in everybody. And again, even for infections, keep in mind that yes, they get opportunistic infections, but they also get run-of-the-mill community-acquired things like influenza. They can get aspiration pneumonia, which admittedly will look a little bit different. So again, don't think that everybody with HIV has an opportunistic infection, especially if you're taking your boards and they're trying to, quote, trick you. So what are the etiology of HIV-associated pulmonary disorders? The things on the left are common, and although I'd like to think that pneumocystis is the most common cause of HIV-associated pulmonary disease, is actually pneumococcus, but pneumococcus, pneumocystis, and in the right epidemiologic situation, TB are the most common. One of the points I'd like to make is on the right, and that is that CMV, Mycobacterium avium, HSV, and Aspergillus are all things that colonize the airways, and it can be colonized or shed for long periods of time. And they're things that in HIV-infected patients, they simply don't cause respiratory disease with any frequency. Now, again, other populations, CMV or Mycobacterium can be terrible pathogens, but these are shed in respiratory secretions. If you find them by PCR or culture or even cytology, I think you should always be looking for some other cause of pulmonary infections. Again, there are some rare cases. There's some case series of 3 or 4 or 5 cases, but these almost never cause pulmonary disease. So if you find them, look for something else that's the real cause. So what about pneumocystis? Whether you call this pneumocystis jirovecii or pneumocystis carinii is a taxonomist interest. Really depends what mid-20th century, Middle European scientists you want to give credit for discovery. This is spread from human to human by aerosols. And interestingly, most infants are seropositive by 1 year of life. And what this means is we get infected and reinfected multiple times during our lives. And this can persist in the airways for a period of time. So again, when you find it by PCR, you're really not sure whether or not that's the cause, although admittedly, if I saw a patient with compatible syndrome and a positive PCR, I treat them. I just keep in the back of the mind, it might be something else. So how do we make the diagnosis now? We've gone from doing lung biopsies to, if you have a good respiratory therapy group, an induced sputum induced with hypertonic saline has a very good result. And we don't do stains so much, we do PCR. And again, in the era when we had stains, this is a silver stain, an immunofluorescent stain, that generally meant that it wasn't that sensitive a test. So if you saw it, it was virtually always the cause of the pulmonary dysfunction. There are plenty of autopsy studies that showed that. The problem is now for pneumocystis, again, just to perseverate on what I've been saying, is if you find PCR in a BAL-induced sputum, it might be the cause. A negative result is very useful because a negative BAL PCR for pneumocystis means that basically you can be almost 100% sure they don't have pneumocystis. But if it's positive, you don't know. And while the sophisticated people will look at cycle numbers, this is not looking at cycle numbers like in blood because there's a lot of variation in terms of what part of the lung was sampled, how good a specimen it was, how dilute is it. So you really can't rely on that. Can you use beta-glucan? The answer is, for me, would be no. There's a serologic test. The rule at my institution is nobody ever orders a beta-glucan because it's too nonspecific. It is positive in a lot of fungal diseases. It's positive in a lot of not a lot, but several non-infectious entities. And if you look at these beta-glucan levels here, and use the Fungitel cutoff of 80, you can see that if you have pneumocystis, there are patients who are negative. If you don't have pneumocystis, there are patients who are positive. So I personally don't see that this is useful, but I've debated this with Paul Sachs and others for years. Not everybody agrees. So here's another question. Your typical patient with low CD4, high viral load, comes in with fever and shortness of breath. The BAL is positive for pneumocystis by DFA. So I'm telling you that the test that I think is the gold standard is positive, but the micro says on the bronchoalveolar lavage, that's positive for CMV and PCP. So what do you do now? So do you add ganciclovir? Do you add prednisone? Do you add ganciclovir and prednisone? Do you add nothing and continue the trimethoprim sulfa alone? And this gets into how many of you are multitasking and listening to what I'm saying, and how many were listening or knew this ahead and didn't need to know. Good, 50% of you would do nothing. And this patient had PO2 of 80, so prednisone was not at least high on my list. So the point here about CMV that I made in that slide with the red things that never cause this is that CMV almost never causes pneumonia in people with HIV. In stem cell transplants and other things, it's a terrible cause of pneumonia. And that if you find CMV in the blood or secretions, it's really correlates with CD4 cells. We've done a number of studies over the years that show that the lower your CD4 cells, the more likely you are to find CMV in blood and secretions. So again, it unfortunately HIV is not a useful test in blood or other secretions. What's the therapy for pneumocystis? Again, trimethoprim sulfa is always the best choice. Parenteral pentamidine is just as effective as trimethoprim sulfa, but very toxic for the kidneys and pancreas, so you don't want to use this unless you have to. Atovaquone is not good for acute disease if it's unless it's mild, because it takes several days to reach steady state. Clindaprimiquine does very well in trials, and you probably use it. I worry that the primaquine is only oral, but in the trials it looks good. And don't forget about steroids, because steroids probably help speed up recovery in anybody with pneumocystis. The only trials have been done in those with moderate to severe disease, namely PO2 of 70 or below on Romer or an AA gradient less than 35. I think sometimes people forget this, but if you have moderate to severe pneumocystis, if you look at people who get standard therapy with trimethoprim sulfa, or when this was done, pentamidine, or those who get standard plus adjuvant steroids, counterintuitively, at least what I thought was going to happen, there aren't any complications with this 21-day regimen, and patients do much better in terms of a lower probability of death. And actually, if you gave it to somebody with mild disease, although it's hard to do a trial with endpoints, they'd probably get better faster also, although with mild disease, hopefully nobody dies. So let's move to CNS toxo. This is a typical space-occupying lesion showing a non-contrast CT, or on the right, a FLAIR image with a lot of edema. I think everybody in this room knows that there are lots of things that can do this. Infectious and neoplastic are major considerations usually, particularly in somebody with low CD4s, is toxo versus lymphoma. The X-ray is non-specific. If you're lucky and find a lymph node or a lesion in some other organ that you can biopsy, you can make your diagnosis. There are lots of serologic tests that are helpful. The serum, the IgG for toxo PCR, we'll get in a minute. Cryptococcal disease, in case this is a big fungal agent, a urine histo. But what we often look for in somebody who has the right setting is we look to empiric therapy. So the perfect patient for empiric therapy is somebody who has a compatible space-occupying lesion. They have a CD4 count less than 100. You almost never see toxo over 100. Their toxo IgG is positive, although you have to be careful in this modern era that some of the ELISA kits that labs use are not that sensitive. So you can probably once in a while see it in somebody who's serologically negative. And if they're on trimethoprim sulfur prophylaxis and really taking it, they're not going to develop toxo. So these are the criteria for empiric therapy. And we generally go for 2 weeks based on this kind of data. But if you look at clinical and neurologic improvement, you can see that within 9 days, 50% of patients are clinically and neurologically and radiologically better. Within 2 weeks, almost everybody is better. So if they're not better in 2 weeks, you start thinking about another diagnosis and whether or not you need to do a brain biopsy or something else. So the definitive diagnosis is brain biopsy if you're lucky and have a serum PCR for toxo that's positive, or CSF PCR that's positive, you have your diagnosis. But as indicated here, it's not 100% sensitive. The therapy is sulfapyrimethamine is the traditional choice. It's expensive. It's not often available. Trimethoprim sulfate is not as well studied, but it appears to be just as good. So I think that really is practically the drug of choice. Clinda and pyrimethamine is also good. Atovaquone is really a backup regimen. Maybe if somebody's doing well and having trouble tolerating one of the other regimens, you can do atovaquone, but the data with that, with or without pyrimethamine, is not as convincing. And we generally don't give corticosteroids or anticonvulsants unless somebody has an increase in intracranial pressure for steroids or they've already had a seizure. Let's see, I didn't mean to keep this. So there are some things that help you distinguish. In terms of CNS lymphoma, they can be distinguished in that they're usually, but not always, solitary, single. They can cross the corpus callosum. A PET scan, if you have access to that, they'll have increased uptake. The CD4 doesn't really help you, and they'll often, but not always, have a CSF Epstein-Barr virus PCR that's positive. PML really shouldn't be in this diagnosis because it's a white matter lesion, not a space occupying. It doesn't have contrast enhancement, so hopefully that's distinguished. The next to last disease I'm going to talk about is cryptococcal disease. This is a very complicated disease the more you know about it. In terms of diagnosis, in addition to the issue about the PCR, if you have somebody who presents with a compatible syndrome and the right a compatible syndrome regardless of CD4 count, one of the things you should realize is that the CSF cryptanagen can be negative for weeks before the serum cryptanagen is positive. So you should get both a serum and a CSF cryptanagen. And again, you can get a PCR, you can get cultures. The culture will take 4 to 8 days, so that's slower. But just keep in mind, the negative CSF cryptanagen doesn't completely rule this out. You should get cultures and a blood cryptanagen as well. What's the therapy of cryptococcal meningitis? It is still liposomal amphotericin flucytosine. Fluconazole is used for consolidation, and a few years ago they upped the consolidation dose from 400 to 800, and then you give a long tail of maintenance therapy with a lower dose. There's a lot of interest in a New England Journal study on single dose amphotericin. So this sounds attractive. You give that with 5-FC and fluconazole for the next 14 days. The problem is this was done outside the United States. This was done with very different antiretroviral regimens. And in this country, this is not recommended by anybody unless you really don't have resources to keep the person in the hospital and to monitor them. But again, the data is not considered robust enough to recommend this. So I'll be interested in whether anybody's using it, but I don't know if anybody's actually used this in the United States. For the management of cryptococcal disease, most experts would keep these patients in the hospital for at least a week because this is a complicated disease. You worry about increased intracranial pressure. You should get an LP at days 7 and 14 to assure the clinical response. And the recommendation is if your culture isn't negative at that point, you should continue the liposomal amphotericin. If you have increased intracranial pressure and you're symptomatic with blurred vision or headache, the approach is not steroids, as we indicated before, it's daily lumbar punctures to relieve the fluid. And that's important to realize. So we don't use steroids, mannitol, or Diamox for that. If you're using fluticasone, you need to do therapeutic drug monitoring. And all of us do serial cryptanagen. It's just not clear that that's useful as opposed to clinical response. So the last infection we're going to talk about is this. Again, another question. 31-year-old male with HIV, not yet on antiretroviral therapy, complains of pink eye and blurred vision. So this is most likely to be which of the following? I'll be impressed if everybody gets this one right. Because Judy Courier said I should put this in to trick you. You look at those fun. Let's see. Oh, good. So 27% of you were not tricked by Judy Courier. 56% of you were. So one of the issues is if you look at the fundoscopic picture here, this is not what we call the classic ketchup and mustard. So this is what CMV is. And admittedly, I think fewer and fewer people look in people's eyes, and even the ophthalmologists, I'm not sure are that good at this, but this is what we call the hemorrhage and the exudates. And admittedly, fundoscopic differential diagnosis is difficult, but this with conjunctivitis and these exudates without hemorrhage is syphilis. And with more and more syphilis in the United States, you just have to keep in mind that not every case of retinitis in somebody with HIV is CMV. So ocular syphilis can be primary, secondary, or tertiary syphilis. It has, like, they always say about syphilis, you can see almost anything. Most of the patients with ocular disease have syphilitic meningitis, and the treatment is always penicillin, maybe ceftriaxone, and you should always try to use penicillin if you can. And don't be surprised even with ocular syphilis if you get a Jarry-Schurkheimer. So the diagnosis, if it were CMV, is you see the mustard and ketchup. You can see the fundus very clearly because unlike syphilis, there's very little vitreal inflammation. The PCR of the blood is not useful. And vitreal taps are almost never done. They're treated empirically. They're often positive, but again, people don't usually use them. And the therapy is antiretroviral therapy, IV ganciclovir if it's severe, PO valganciclovir it's not, and the ophthalmologist might choose to use intravitreal injections, particularly if it's severe, although that can cause infections or retinal detachments. Two final issues, and then I'll open it up to Judith for questions. One is, when do you treat when do you add antiretroviral therapy? Traditionally, we say after an opportunistic infection, we do it within 2 weeks. How quickly you do it depends on how the patient is doing clinically and your own comfort with dealing with iris if it occurs. The 2 or the 3 exceptions are TB, where you generally wait 2 to 8 weeks. If it's TB meningitis, you wait longer. Again, you can look up the specifics. With crypt meningitis, the recommendation is to wait generally 4 to 6 weeks unless their CD4 count is less than 50. But I think people are getting more and more comfortable with starting antiretroviral therapy earlier. So I'm not sure that everybody waits this long in patients who are doing well clinically unless they have CNS disease. And where you want to start it immediately is if they have a quote untreatable disease where there's no treatment, like PML or crypto. So the last thing I'm going to say before Judith intervenes and stops me is one thing about a tumor. Now, we know that almost all AIDS-defying or AIDS-associated cancers are related to a virus, but I want to bring your attention to a recent change in the guidelines that just came out last week, and that is about screening for anal cancer. If you look at this, I think, very impressive figure, if you look at cervical cancer or anal cancer, whether it's a man or a woman, in HIV, there's a phenomenal increase in the incidence of cervical and rectal cancer. And I think cervical cancer screening has been done for a long time. Anal cancer screening has not. So the HIV guidelines now recommend high-resolution anoscopy as part of anal cancer screening. And that presents a couple of opportunities and a problem. This is based on a study that was done by Joel Pileski and the AIDS malignancy group on the treatment of high-grade squamous intraepithelial lesions. This study showed that among people with HIV over 35 with biopsy-proven anal high-grade lesions, the risk of anal cancer was much lower if you treated that early lesion than if you just monitored them. So this is a complicated issue, a complicated thing. I don't want you to read this, but I think the point is, I don't know a lot about HPV, particularly with anal screening. I think this is a new approach to most of us, but given the incidence of anal cancer, I think we can significantly reduce the incidences if we have high resolution anoscopy. Again, there are good diagrams in the guideline in the last week to work you through that. The problem is that very few people have access to high resolution anoscopy. So this is an aspiration. Whether it's a reality in the next few years, I think there's going to be a lot of dispute over, but at least you should be aware of this. So the post-test, which of the following is the most sensitive to detect cryptococcal species? Well, let's just give them 5 seconds for this so we have questions for, and I hope everybody gets the answer to this. They won't give me my wish for 5 seconds. Good, nice. 6% of you came in late in this. So the next post-test is? Let's see. Oh, here we, oh, this isn't good to give the answer. Oh, well. I actually, all right, so you already saw the answer, which, well, let's see. Let's skip the post-test answer as I have these out of order. So in any event, we're happy to answer any questions. And Judith, I'll turn it back over to you.
Okay, great. Yeah, it looks like everybody almost got that second one right about the contraindicated live vaccine. So thank you so much for just an incredible tour de force of managing opportunistic infections, prevention, and treatment. It covered a lot of territory, and we do have a couple of questions that were submitted ahead of time and also along the way, and also for just bringing in the HRA at the end. One of the participants said, for someone who does HRA in my clinic, thanks for mentioning this. So I think it's great that guidelines take into consideration when it is and when it isn't available.
Yeah, let me make, not to preempt, but about the guidelines, that person might also want to know, if the study was published in 2022, why did we wait till 2024 to come out with it? There's a tremendous amount of disagreement as to which patient populations this was relevant to, and how to interpret the cytologies in HPV, whether they should be interpreted together, whether you needed one, whether you needed the other. So without going into detail, this was very complicated, and I think it's still going to be controversial. So you just have to stay tuned, and this will be a good topic for IAS-USA to focus on.
Yeah, I think it's a topic for a whole other webinar. All right, so I kind of tried to divide the questions up into different OIs, and I think just starting with PCP, in somebody who has poor CD4 recovery, the viral load might be suppressed, but the CD4 is kind of hanging out. How long do you continue? And is there really any data? Like you said, a lot of things that we do now are expert opinion. What's your approach for those kind of that kind of scenario?
Yeah, I think this is, as you implied, someplace where you need a clinical judgment. We follow several hundred patients here who don't have a good CD4 recovery, even though they have a suppressed viral load, and they almost never develop serious opportunistic infections. So my presumption is that if you can get the viral load below the level of detection, they're pretty protected. I don't think anybody has the data to prove that. So it depends how risk averse you are. But I personally wouldn't have any hesitation if somebody had been on a regimen for say 6 months and their CD4 count hadn't come up, as long as their viral load was suppressed, I think you could probably stop prophylaxis. But I'd be interested, Judy, if you had a different view on that, because I suspect you follow a lot of these patients also.
I see this sometimes in older patients, and sometimes also it depends on what their tolerance to the Bactrim is. If they have, sort of below white count or renal issues, sometimes it's a judgment of, is it doing more harm than good, in terms of stopping it.
And also, I'm sorry, some of the patients will also tell you that no matter what you recommend, they're not stopping it or they are stopping it.
Yeah. So Peter Solberg asks a really great question. When some folks come in with CD4 less than 200, but they really are asymptomatic and have no other active issues, they just start ART alone and just hold off on the trimethoprim sulfa, thinking that they're going to get a viral load in a couple of weeks, and they respond so quickly. He's asking, is that crazy to just take a little bit of a chance for a short period of time?
I mean, I don't think that's crazy. I think that probably is looking at the science and looking at the experience. Again, one of the real problems, as I alluded to before, with the OI opportunistic infection guidelines, is that there's so little data in the last 20 years when we have these new regimens. Like the patients whose CD4 count hasn't gone up, once you get the viral load down, I suspect that you have a lot of immune reconstitution. So I would suspect you could probably get away with this. The trouble is there just isn't any data, and it gets into a longer debate when you have guidelines. Is you want guidelines based on evidence, or you want it based on clinical practice? And with the OI guidelines, we try to go in the middle, but it always makes me shiver a little bit when people say they only want evidence-based guidelines, because a lot of things that I'd like to know what the experts do, even though there isn't any data. So I would say what you're doing is not crazy, and I think in many situations it's reasonable.
Yeah, and maybe in larger, maybe data could emerge from larger health systems that do this routinely and could help contribute to really the evidence base for the rest of us. You mentioned something about one of the questions were any alternatives to sulfa, pentamidine, dapsone, or atovaquone for PJP. You mentioned something about a drug in development. Do you want to say more about what that is? There anything to be looking out for in the future?
Yeah, I think there's a drug called tefenoquine, which is used for as an anti-malarial. In vitro studies and animal studies, it looks very good for pneumocystis. The trouble in 2024 is that no one wants to sponsor any studies with that. So I think the pharmaceutical sponsor would like to do that, but it's hard to get enough patients and it's hard to get anybody to fund that. So I would doubt that's going to be developed. And I personally, even if I could get it from the pharmacy, probably wouldn't risk giving that instead of trimethoprim sulfa. But it looks like a great drug, and it just is one of the problems that we have to face in that how do you develop drugs for niche populations?
Right, great. Okay. Then a couple, just to acknowledge that our audience today is a global audience. And there's a question here. Sorry, got my question from Paul Yanga from Nairobi about the Hep B vaccine. There are a couple of questions about this. Heplisav is not available there. They have Energex and a vaccine from the Serum Institute of India, which he says it's been working well at maintaining protective anti-HBs levels up to 3 years. In countries that don't have Heplisav, what's your thought?
I think the other two recombinant vaccines are just as good. There's no evidence that they're any better than Heplisav. It's just that they're 3 doses rather than 2. But I don't think in terms of efficacy or safety, there's any preference among the 3. And just to respond also about our audience outside the United States, for the guidelines, we focus on the United States for 2 reasons. One is that there's so many different situations in the world in terms of drug availability, in terms of frequency. I think it's hard to have one size fits all for the world. And also, nobody asked us to do this for the world. NIH asked us to do this for the United States. So we're really focused on the US, although admittedly, a lot of the data comes from outside the United States.
Okay, great. Another question, just moving on to crypto. Do you routinely do the crypto antigen in your clinic for people starting ART? Is a protocol in place, or is this sort of left up to providers to remember to do it, to order it?
Yeah, the answer is that I would bet if we audited the charts, very few people do it. This is another controversial issue where there are studies done in South Africa, then there are some studies in the United States. And I think clearly the patients who are asymptomatic, who are detected to have cryptantigen, do worse than those who don't. And the higher your titer, the worse you're going to do. On the other hand, if you started those patients on an antiretroviral therapy and didn't do anything else, I don't know whether they developed disease or not. So again, as long as you're going to start people on antiretroviral therapy, I'm sort of ambivalent, although the guidelines committee, John Perfect is the world's expert on this. He feels that this ought to be done. So again, as well-informed clinicians, you have to decide what to do, but I can say that I would bet that many of my friends that I work with don't do it.
Okay. There was another question about TB prevention. I think this is a really important point from iPhone about should we be emphasizing extension of ART to the 30% of people living with HIV not yet on ART whose TB risk is tenfold higher, rather than treatment of latent TB in those already suppressed whose risk of TB is much lower. I think the answer is yes. We should be trying to figure out how to extend the benefits to ART to those who are not yet suppressed. What about just using in people who are in and out of care and not able to be suppressed on ART, TB prevention? Does your strategy change? Is that 1 HP, which can be completed in a month's period if somebody's not on ART, would you think about using it?
I mean, certainly think about using it because if they're not on ART, you're not worried about whether they're on an efavirenz-based regimen or not. I mean, to me, this is an implementation problem, not to seem to trivialize it, but I think we have strategies. The question is, can you do directly observed therapy? Do you have community workers who can go out and find people so you're not giving them, partial treatment and potentially causing resistance? So I think all of us realize that we need to have a more successful effort to reach out to the people who are not taking antiretroviral therapy and therefore not in care. The question is how to get them to take any other regimen. I don't know whether in Los Angeles your program, Judy, has a way to approach these patients.
I don't have a simple answer. I do think that 1 HP, the issue with dolutegravir is whether you double the dose, you give it twice a day, if it's safe to give with rifapentine. This is a big issue globally, whether the drug interaction is clinically significant, and this need to double the dose is programmatically has been really challenging. So I think that may be a question for a different audience, but a critically important issue in our efforts to try to prevent TB. A couple other, so for CMV, you mentioned, I think this question came up right during the webinar, these cases of PCP pneumonia where the CMV comes back positive, or CMV DNA gets sent. In that setting, do you do any surveillance? You ever use CMV DNA as a test for surveillance?
We use it, as I'm sure you do, all the time in transplants, not in HIV, because again, I think you can predict what the CMV is going to be based on your CD4 count. So, and I don't think there's no evidence that I know of that in this population, we're not talking about other populations, that it is at all predictive. It's certainly going to be very non-specific in that, there are lots of people who are going to be viremic who will never develop end-organ disease.
Yeah, I think it's such an important issue. A question about ocular toxoplasmosis. Do you ever recommend any prophylaxis for that if someone has ocular toxo?
One of the interesting things about toxo is different manifestations in different populations. And certainly in immunologically normal people, in older adolescents and young adults, ocular toxo is common. In HIV, it's not very common. Again, it's mostly cerebral toxo. And it's interesting that if you look at cancer patients or organ transplants, they largely get hepatosplenic disease and not cerebral disease, whereas HIV patients get cerebral disease. So it depends on the patient population. And I suspect that, like at UCL, you probably see a case of ocular toxo every once in a while. The question is always, how certain are you of the diagnosis? But I think the bottom line is that ocular disease is so uncommon that we don't consider that in terms of screening or prophylaxis. But again, if the CD4 count is under 100 and they have a positive IgG, I think you do have to worry about cerebral disease.
Okay, and just one other question about toxo, and I want to jump back to CMV. Do you still send toxo antibody on people?
I don't. That goes under the category of something that is recommended and probably rarely done. I think, again, if you're going to start somebody on trimethoprim sulfa or even atovaquone for PCP, then they're covered for toxo anyway. So I think most of the time it's not that useful. If you have somebody who comes in with a cerebral lesion and you don't know their IgG status, I think it's helpful there. But again, you got me on another recommendation that's probably good in theory and not practiced in many places, including with my friends I work with.
And then just back to CMV, Dr. Daryl Hawley raises the point about not treating CMV if it's not causing active disease, but there has been a lot of research about the role of CMV contributing to inflammation in people with HIV, living with HIV. And I guess one of the questions is whether, our approach to this might change if we think that suppressing that inflammation would be good. I guess it depends on what the tools we have for suppressing CMV are. Certainly not IV ganciclovir or oral ganciclovir at this time. I guess I'm sort of answering this question myself, is that I don't think we're at the point where we have data to say that suppressing it makes a difference clinically.
Yeah, well, good. I'd rather you answer that than me. But I think there are a couple of issues. CMV is always, it's like EBV. It always intrigues people. And you find it in the ICU population or people with cardiovascular disease, the question is, what is its role? And in HIV, the question to me is the presence of CMV, is it the CMV that's causing inflammation and all the problems associated with it? Or is it the fact that if you could suppress their viral load better and their CD4 count went up, the CMV would go away and that would decrease inflammation. So I guess the question is it the fact that if they're CMV positive, is it the CMV or that they're not as immunologically reconstituted as you'd like them to be?
Yeah. Okay, a question from David Hardy. Dr. Mazur,
oh my God, David Hardy.
I think it's David Hardy of Los Angeles. What's your opinion on diagnosing PCP based primarily on the clinical basis without any diagnostic laboratory support?
Yeah, well, I can say that David, from his time in Los Angeles and DC, always asks impossible questions if that's him. But I think sometimes you have to be practical. I think if you're in the clinic and you have somebody who is has a typical presentation and they're not that sick, you can try that. It's just that, the disease is unpredictable in terms of when they're going to fall off the cliff and get worse. So, sometimes that's the best you can do, and so be it. But I guess if I could, I would always rather at least get an induced sputum. But I know that's not practical in a lot of clinics.
Certainly, and certainly empirically starting treatment while you figure out what's available diagnostically. Well, we still have a couple more questions. I know we're running out of time. Maybe this is a great topic for a more interactive type of webinar where we can have more time for questions. But in people with advanced HIV and cancer who are going to undergo myelosuppressive chemo, and starting ART, would you consider MAC prophylaxis in that setting? Just got to have one MAC question in here before we close out.
Yeah, I wouldn't, because intuitively, I would have thought that in transplant patients, cancer patients, disseminated MAC or MAC bacteremia would be common. It just isn't. There are populations that get MAC that have genetic deficiencies and so on, but just the fact that clinically you never see it, I wouldn't worry about it in that population.
All right. And Dr. Hardy does confirm it is him. Just terrific. I'm sorry I didn't get to answer every single question. Wonderful participation by our audience. Dr. Mazur, thank you so much. I have a couple of closing slides, but just really appreciate that that talk. So the information about how to claim CMV will be emailed out by 5 p.m. Pacific time. And we really do want your feedback about this content and delivery and topics for future programs. And also coming soon, if you haven't tuned in to Going Antiviral, this is a phenomenal podcast. And the next one is on the hot topic of the impact of GLP-1 receptor agonists with Dr. Suman Srinivasa. So that is not to be missed. And then we have another webinar on the tricky issues around implementation of long-acting drugs for treatment and prevention, just coming up next week on July 23rd. And syphilis on July 29th. This will be also just a terrific review of a very timely topic. So I encourage you to tune in or listen on demand. And then continuing management of substance use disorder in pregnant people with HIV coming in August. And an overview from the International AIDS Conference coming at the August 20th. So that's also to be anticipated. So we have a virtual course on opportunistic infections, forgotten but not gone. That's going to be on September 10th, and that's co-chaired by Dr. Constance Benson and Dr. Roger Badimo. So if you want more OI learnings, I encourage you to tune in on September 10th. And then just mark your calendars for CROI next year, 2025. We'll be on the West Coast in San Francisco, March 9th to the 12th. So thank you so much for participating. Please do send us your feedback, and thank you all for being here today. And thank you so much, Dr. Mazur, for that phenomenal lecture. Take care.